document from the Institute of Healthcare Improvement on their frail elderly project. And you'll see that the very last one there is manage a trustworthy, effective, responsive local service production system with a competent, thriving workforce. Really interesting to have that as a piece of what it is going to take, at least in one group's view. What will a local manager need if you agree that we might try out local management? Well, first thing is we'll need tools for monitoring. We'll need skills in coalition building and governance. We'll need visibility and value to local residents. People will have to trust this entity. We'll have to have funding, perhaps from shared savings out of the medical side. Have some authority to speak out, cajole, or control. I'm not sure what level we'll need. And a commitment to efficiency as well as quality. We can't just keep pretending that somehow just pursuing quality is going to ever get us there. We are going to have to learn to bite the bullet and take some real cuts in throwing money at problems and instead working on the priorities. So we've been doing some work on the kind of data. This is a transition map for Cincinnati. It's amazing when you show people who work in Cincinnati or in any other community this kind of a map, they start seeing how much they're interrelated. Here's a time trend for Cincinnati with regard to readmissions. We have been very loath to allow geographic concentration. When I was the head of cancer and chronic disease for the city of Washington, D.C., we had 40 home care agencies, each of which was obliged to serve any home in the city, which meant that if you had a Medicaid patient in an apartment building in which there were 8 other Medicaid patients, all of whom needed home care, you could have 8 different agencies coming in, every one of which required 3.5-hour minimum because they didn't want to move people all over the city. Since people mostly need help first thing in the morning and last thing in the day, you have split shifts, you could end up with 16 different aides in under 8 different agencies to take care of 8 people in an apartment building. There is no other service we move to the home in which we would allow that kind of stupid inefficiency. For heaven's sakes, pay the aide a living wage and let that aide move around and see people in sequence. But for that, you have to allow geographic concentration. So we will be much more efficient if we allow that. We can utilize some local strengths, solve local issues. We do have to worry about monopolies and allowing there to be a slide into very bad quality control. But there are other ways of managing quality. A piece of our problem for the frail elderly is that we have made medical care an entitlement. With a blank check, you can get anything, even my Provenge. But we have made social services just kind of occasional gap fillers, and we close them down and we start them up, and nobody can quite rely on anything. And then we didn't ever develop any integrator. So here we have a population that needs the housing, food, nutrition, transportation, and medical care, and we keep them entirely in different silos. We even go to different meetings. This is one of the few places where problems of retirement security and problems of social needs and problems of medical care come together in a group of people. None of our literature does that. None of our professional meetings do that. There's no integrator for an individual. There's no integrator for a community. And there's no integrator even for the research literature. In addition, we are bizarre in our overemphasis on healthcare. Everybody here is used to seeing the bottom graph with the US showing a high proportion of GDP going to healthcare. Look what happens when you add on social services. We're right in the middle of the pack. What is really screwed up is our ratio. Virtually every country spends almost twice as much on social supports as they do on healthcare, and we spend 80% as much. So we need not only a rebalancing out of institutions into communities, we need a rebalancing out of medical care and into social supports. So I've begun thinking about an ideal production system for a community. This is an estimate, roughly, for Washington, D.C. 600,000 people, about 5,000 frail elderly at any point in time. Some estimates about sort of how many people would be taken care of by what sorts of ways. It takes a good deal of work to get through. But here's sort of the bottom line. You could think about the production system for Washington, D.C., for Annapolis, for Montgomery County, for wherever you want to think about. Even though the home care is owned by 40 different agencies and the hospice by 12, and hospitals by a dozen, think of it as a geographic production system. What is it that you have too much of? What is it you have too little of? What is it where there's a quality problem? And then where would the conversation happen as to how to fix those problems? We don't have a place to have the debate. It's marvelous to be in, say, Sweden, where they know right where they'd go. They'd go to the county council committee on elder care. We don't have a place to have the discussion. So we need to develop the place to have the discussion. We've been looking for where these things are beginning to crop up, and they are beginning to crop up. People are seeing these sorts of problems. So we have a place with a voluntary coalition. We have a place where a home care agency is beginning to take on these patients and trying to contract, or a social services agency. I'm going to show you just one here. This is a county social services provider who is contracting with integrated healthcare systems, managed care insurers, and delivering services through community social service agencies and serving as the network. Really an interesting set of developments. What if we actually allowed this? Or heaven forbid, we actually encouraged it? What if we said not just states, but states could start regionalizing? It's already being done in the duals. Oregon has 7 divisions. Colorado has 7, I think. Michigan is going out into 5 different areas. And they're establishing management in those areas. We could build on that. We could have a way to manage the elder care system coherently across social services, across long-term care, and across medical care in the interests of all of us. So I've put in some resources. There's Jerry Garcia's wonderful line. We're all old people in training. We all face the doom that we have set up. We run the risk of ruining our economy if we continue to spend at this rate, but we also do not want to turn our backs on one another. And I think that the only way through is going to be a deliberate pursuit of efficiency as well as quality, and it's going to require some degree of local management.
I'm not going to do a PowerPoint because I'm the last one to go. And I have attention deficit, and I have to say, after being through all the rest of the speakers, my notes are a mess. I have so much to say that it's really challenging. And when I first walked in, I have to start off by telling you a funny story. When I first walked into the room and I saw the double monitors, it harkened back to a similarly hot and awful day in New York City that I was asked to come and speak to the CMS regional office. This is back when I was with the Medicaid directors. And I was staying at a hotel, and I asked somebody from CMS, how many blocks to the regional office? And they said 10. And I said, I like to walk 10 blocks. So I started walking the 10 blocks, and I realized 10 New York City blocks are a long way to go. So I arrived in there, and I'm dripping wet. And they had visuals on both sides, plus in front of me. So that's immortalized forever. I have the thought of having that experience. So I will always take a taxi when they tell me it's 10 blocks in New York City from now on. I'd like to talk about the things that keep me up at night. I have terrible insomnia. Many of you have received emails from me in the middle of the night because I don't sleep very well. And part of it is there's a lot going on in my world now that I'm in aging and disability services and moved out of Medicaid. Yep, that's right. It's a lot more complicated. In the Medicaid world, my first day on the job in the aging and disability world, James was there. Oh, he just left. But James was there as one of the officers at Nashua. And I remember somebody standing up and saying the budget for the older American, or for AOA, and I literally thought there was a decimal error. And I raised my hand and I said, excuse, huh? I just left a $340 billion job to come to do what? Because it was $1.4 billion at the time, and I remember thinking, this has got to be wrong, because this is the way that we can really save the Medicaid program billions of dollars if we would just invest a little bit on the front end instead of putting everybody into the healthcare system. Here's a stunner for everybody. The BIP program, the Balancing Incentive Payment Program, excellent program, really worthy of all of our love and devotion, and I'm so glad that a lot of states are picking it up. It's $3 billion. A demonstration grant program at CMS is funded almost twice as much as all of the Older American Act funding. I think everybody has to stop and think about what that really means when you start to think about what the value is that we're placing on the Older Americans Act. I, for one, would like to stop calling it the Office of Duals and call it the Office of Triples, because I think it should be that's the front-end system of the Older American Act, then Medicaid, and then Medicare. Think about how much money we could save if we stopped letting people spend down into the Medicaid program and spend a little on the front end of the Older American Act programs. But everybody up here has already said what I've said, or are about to say. The states have faced 4 years in a row of budget cuts through the economic downturn. The only state that was unable or was able to hold fast was North Dakota. Every other state faced at least 5% each year, at least 5% cuts over the 4-year period. That's significant. We've lost 1/5 of all state aging and disability workers. They've either been retired or have been laid off because of the funding cuts. The states have done everything, and the locals too. States and AAAs have done everything in their power to not cut services, which means they've turned the lights off, they've stopped doing everything else so that they can not cut services, but they're at their end at this point. There's nothing left to cut except for services. Many of you, well, everybody in your packet, they were so generous here at NASI, and they put in your packet our new infographic. I think it's really quite helpful to look at it in terms of pictures. I think better in terms of pictures, so that's what we did, is we tried to, in picture form, explain what the Aging Network does and why it's so valuable. But if you look at it, it's kind of also really sad that we're serving about 10% of everybody who's eligible right now. Now, does everybody that's eligible over the age of 60 need to be served? Absolutely not. There are lots of people over the age of 60 for whom it doesn't make sense for them to receive the services of the Aging Network. However, we're not even serving the people up to 130% of poverty. They're not getting a meal. And so what does end up happening is those same individuals end up, especially those over the age of 85, end up getting dehydrated and end up in the hospital and then end up in the nursing facility and becoming the duals. It doesn't make any sense the way that our system is working right now. We know from our survey work with AARP that the requests for information over the course of the economic downturn have been, number one, just general calls for information and referral. Number two, food. Number three, financial resources. Fourth, transportation. We're talking about basic things. And so I think that it's a really important thing to keep in mind as we go forward. What would we do, and Kathy Greenlee always says this, could we do more with more? What would we look like if we had more? How much better could we do, and how much could we save if we were part of a triple solution? So the sequestration, I want to talk about that a little bit, because in addition to all the budget cuts that the states had to take, in addition to that, the Older American Act funded programs were not saved from the sequestration. And it varied state by state, and it's varying how they're rolling it out. But we had a number of states with double-digit reductions, including Georgia, Nevada, North Carolina, South Carolina, and Washington. Colorado was the hardest hit with a reduction of 15%. in Older American Act funding this year. I think that when you look at that, on top of the cuts that they've already been taking, there's no wonder there's a waiting list in every state across the nation for services and supports. I'm always a girl who looks at a glass half full, and I'd love to on this one, but I'm not so sure that it will happen. I do think that the sequestration is here to stay, which means that it makes it that much more important that we fight to get a realistic authorization and appropriation for the Older Americans Act, because this level of reduction in services is just unfathomable that we're allowing this to continue. In addition to the changes at the state, we're looking at the consolidation of all of the state agencies. Many of the states have moved in, from just being aging into aging and disability, and now also aging and disability and developmental disability is also being merged in. We have a number of our commissioners that have retired, so we're looking at doing all of these changes with people that haven't been on the force for very long. I think we have 5 in the nation that have more than 5 years experience at this point, and the rest have under 2 years experience, so it's a really challenging time. The shift with managed care, as James and others have spoken about, also is shifting the way that we do our work at the Aging and Disability Networks. We have to think in terms of business models and all sorts of different challenges. I want to just bring up, I have 3 minutes to go, so I'm going to do 2 more things. We have 98 days to go and counting until the Affordable Care Act starts open enrollment. Information and referral and assistance is one of the top jobs of the Aging and Disability Networks. Both the CILs and the area agencies are called on every day to provide unbiased information and referral and assistance. They will be called on to provide answers on open enrollment because seniors will be confused and they will call, and people with disabilities will be confused and they will call, but also because it's open enrollment in every of the 28 states for managed care, and it's also open enrollment for Part D. So all of you are my friends in here, and I want you to just think about that as we go forward, because we have a little bit of a Bermuda Triangle about to occur. It's not 98 days until just the Affordable Care Act implementation. It's 98 days until we have open enrollment for 3 major programs for which all of us serve members, and it's really important to get the word out. There's about to be a lot of calls coming into all of us and a lot of confusion. Lastly, it's so hard to go so fast. I just want to make a plug and a push for Adult Protective Services. The number of cases of Adult Protective Services sadly has risen every year in the last 5 years, and the number of caseworkers has also sadly declined. We have no federal funding in the nation for Adult Protective Services. Child welfare was founded on the backs of the ASPCA. The ASPCA CEO looked at a crisis happening with children in work camps and decided that he was going to find the child welfare movement. And we're now 60 years plus, and we still have nothing for Adult Protective Services. I think the time is now to come up with the standards and the protocols and the federal funding for Adult Protective Services. And I really hope that we can engage in a real thorough debate on how to finance that, because I do want to say that a lot of the people in Adult Protective Services, what ends up happening is those people are institutionalized because they're removed from their home and there's no place left for them to go back, and they end up back in an institutional setting. And so it's a really important part of the healthcare system and continuum that we look at the Adult Protective Services program and we finance it at a federal level and we define it at a federal level. In many of our states, we don't even have the same definition, and if you're 18 to 65, call 911 because there's nothing for you. That's not good enough in 2013 anymore. We really need to define it and get it caught up. I'm going to leave with a funny story, one quick funny story the timekeeper's right in front of me. When I found out that Alice Rivlin was receiving an award tonight, it reminded me that I was so very proud to have her as one of my professors. And I have this really quirky part of my memory. I can't remember people's names very well, but I remember what they wore when I met them. And I remember what I was wearing when I met them. So I was thinking back to when I met Alice Rivlin the first day of class at University of Maryland. She was teaching DC budgeting. I mean, I was so lucky that I had her teach for a whole semester DC budgeting. But I can't get it out of my head what I was wearing because it was crazy. I had on sneakers because I worked full-time at the National Association of State Budget Officers, so I had on my dress, a polyester dress with a red bow. Oh God, it was awful. But most of all, I had a perm and pink glasses this big. So Alice would not recognize me, I hope. Please, 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 I hope she won't recognize me, but NASI is doing a great job by giving her an award. She so deserves it, and I'm very pleased to have been a part of this discussion and hope that we'll have a lot of questions that come forward.
Thank you. Absolutely fabulous. I like those pink glasses. I think I want some. I would like to pick up on some of the points that were made. There were any number of really valuable points made, and one of them is sort of the scattershot way that we look at the social services side. Obviously, that's been a major theme running through our discussions. And it's my understanding, I don't know if this is true, but that there's some thought about restoring some funding for meals, but not other parts of the social services support system. And I'm just wondering, Martha, if you could comment on that.
I have some real trouble with it. It's not problems. I have some trouble with it because for a number of reasons. The first is that if people can't get the information about getting the meal, that's no good. If they can't get the transportation to get to the meal, that's no good. If they can't get the respite, that's no good. And I'm afraid that it would come at the expense of the other programs. Meals are 40% of the Older American Act funding that goes into the states. So it's a huge and very important and vital part of the Older American Act. And there's no question that if people are fed, they're healthier and they don't end up in the hospital and stuff. But my nervousness is that we wouldn't receive the same, we would have to take the cut to the rest of the Older American Act programming, and it's already suffering so very much that I'm not sure that it could forestall that cut.
Thank you. Okay, you all would love to hear some questions from you. If you have any, please go to the mics. Meanwhile, I'll throw out another one, and this is kind of a broad one. We know that we have some staff here from the Long-Term Care Commission and maybe even some commissioners, and we know that this discussion is meant to inform their thinking. So if all of you could just take a minute and sort of think about what your most plausible, pragmatic 1 or 2 or 3 recommendations to the commission to seriously consider, I think that would be great to hear. You can take it in whatever order you want. You go.
So luckily I had a question like that in the talk I gave this morning. So, so I would recommend 2 or 3 pragmatic things. First, I have long argued that long-term care insurance is underregulated, and in particular, I think it is a real problem that long-term care insurance benefits are not automatically indexed for inflation over time. So if you're buying a product that you're not going to be using for 20 or 30 years, then if it's not inflation adjusted, then you've basically bought yourself a useless, worthless policy because inflation will make the benefit worthless. That notwithstanding, and despite the fact that everybody recognizes it, There isn't a single state that requires long-term care insurers to provide inflation adjustment. So that, I think, is something that could be addressed. The second thing is, as people who know my work know, I've advocated a social insurance program for long-term care for a long time. But I think we shouldn't ignore possible fixes to Medicaid. Medicaid has an administrative system that's in place, a financing system that's in place. We could get things done quickly. And two things I would like to just put on the table are, one, raising the financial eligibility standards. We haven't raised the asset limit for the SSI population, which forms the criteria for Medicaid, since 1984. So it's basically $2,000, and it's been $2,000 for a very, very long time. If we're concerned about impoverishing people, then we can raise that level of assets. We can do that. The other thing is 34 states provide personal care through the state plan, but that means that 16 states, 17 states don't, and we could make that mandatory, and that would do a lot to expand home and community-based services to people who need it.
Go bold or go home, I think, right? So what if we flip it and make institutional care the waiver and make waiver services mandatory? That'd be one. Number two, fully fund the Older American Act up to the rate that it was funded in 1980 in real dollars. Three would be, obviously, to create and fund an adult protective services program that's financed at the same level that we finance the children's program. And then fourth is not as complicated, but I think is really critically important to the overall goals of our association and many others, and that's to define disability in a little bit of a different way. There's 64 definitions, last time I checked, federally, of disability, but the primary one is inability to work. And there are so many people that are disabled that want to work and are held back by that definition that I think we really need to look at that.
Okay, I'll try some out, see what you think. I think that we should insist upon comprehensive care plans for everybody who meets whatever our level of disability is, and that those should be held to a high standard, and they should be available across all settings and available to add them up. If I had 5,000 good care plans for the 5,000 frail elders in Washington, D.C., I could geomap where's food needed, where's direct services needed, see how, whether we have an oversupply or undersupply of any particular supply item. But you have to have the decent care plans. At the present time, ONC is undergoing some ongoing debate as to whether they'll even put care plans into meaningful use. So at the present time, the only thing that's in meaningful use is a yes/no on advanced care plans, not even the actual advanced care plan. So the most important thing in the care of very sick and disabled people is missing from our electronic health record that we're pouring billions of dollars into. Second thing I think is that I would generate data that matters. How could we possibly be running a system that is anchored in chronic conditions and not even have disability at the ADL level in our record system? So let's start getting ADLs in, let's start getting symptom management in, let's start getting what people's goals are, be able to